All right, I think we're all getting on. Good morning, everyone. Good morning. Before we get started and allow everyone to get their cameras and so on and so forth on up and running, do we have any questions about anything? No? Okay, while we're waiting for other people to get their cameras on, do you guys have any questions about competencies? Because we're close to the middle of the semester. We're close to the middle of the semester. You're changing rotations this week, right? Good, perfect. So there are 3 things you should be doing. 3 things in clinical you should be doing besides all of your PPE, safety, besides all of that. You should be recording your exams in your exam log. You should be recording your exams and your exam logs. You should also be, at the end of every rotation, evaluating your area. So you may have worked with multiple people. I suggest you do 1 per rotation and make sure that you evaluate the person that you worked with the most. If your person that you worked with is not in the computer, it's not a selection, then we need to get that tech to register. They have to register for Trajexis. We've had a lot of new onboarded techs who are not registered in Trajexis. I'm going to ask your assistance in helping me remind them how to get into Trajexis, or they need to get in Trajexis. Okay? Third, so we had exam logs, we have rotation evaluations. It'll also be called clinical instructor evaluations inside of your Trajexis. The third thing is, once you complete a competency, Mr. Fung sent out a step, a list of how the competency is supposed to be established, right? Indicating once you get your request, you indicate to your technologist that you're ready to comp, right? On that request. This is your opportunity to review the request before you set up your room, get everything ready, and then commence your AIDIT, okay? The technologist, if they have to step in for any reason, your competency does not exist anymore. Thank you. So with that being said, make sure that you are following the steps. We have spent a lot of time educating our staff how the process is. If you forget to shield, meaning you can shield, it's not going to be in the objective, that is an automatic failure on your competency. Okay? So once you complete the competency with the technologist, you will immediately, within that day, 2 days, notify a faculty member, okay, to get your evaluation, your image evaluation completed. There are 2 grades that go into a competency. The skills portion, assessed by the technologist, and the image evaluation, your knowledge on how you positioned the part to the image receptor, how you positioned the CR to the part, how you manipulated the body position, how you collimated your marker placement, shielding, all of that takes into play. How many of you have completed your competency, your chest competency, your required competency? Thank you. Okay? So we still have about, 3 more rotations? Make sure you scout it. Now, if you are looking at the rest of your schedule, and nobody should have no areas where they can achieve a chest, you are literally placed in areas where you can achieve a chest, maybe in not one rotation, but in the next one. Do not wait till the very last rotation, because your stress levels will go high. Okay? Are there any questions about that? No? No questions?
I have one.
Go ahead.
So I did I comped on a wrist, a 3-view wrist.
Okay.
But accompanying those X-rays were, like, I believe it was a knee and maybe a tip field. So I didn't do those. I just did the the wrist. I did the 80, and I did everything else. So will that still counts, even though I'm not tested out on those other areas?
Correct. It will count if you only identify to your technologist that you were comping on the wrist. Everything else has not been demonstrated to you. So that is not an option. However, only if you told your technologist, hey, I want to pump on this wrist, and you started that, ate it, and so on and so forth, then you can pump on that wrist. The tech has to put it in for you. The only way the tech will not put it in for you is if you did not identify beforehand that you were comping. Okay?
Thank you.
Good. Now, let me kind of fast forward just a little bit. I'm only going to take about 2 more minutes. What happens in the future? Because I got the crystal ball. I've been here 12 years. Let me tell you what's going to happen in the future. If you do not get your image review scheduled, you comped, you're waiting on the technologist to put it in, and they haven't put it in, and you've let it go by the wayside because you're going to come back to me in the last 2 weeks of the semester and tell me, Ms. Laura, so-and-so never put it in. I'm coming back to you. That yes, you may have notified them, but how are we going to expedite it? How do we do that? We talk to faculty. Let's just say Daniel didn't get his competency completed by the technologist. It's been a week. Ms. Laura, I've reached out to so-and-so. They haven't put it in. Can you influence them by any chance? I sure can. I sure can help you. Does that make sense? But if you allow it to go by the wayside, it expires after 2 weeks. So that comp is null and void. Does that make sense? It is your responsibility. You are accountable to make sure you see it all the way through. 60% of your clinical grade is competencies. That is a course in itself. Does everyone understand that? Good. All right. Are we all awake? Are we ready? Yeah? No, this is what I see. Can we get better? Can you motivate me to be engaging? I really need your energy to filter through this monitor right now. Thank you, Luke. I love it. Okay. All right. So let's go ahead and go on into, I gave you a set of, so I gave you this PowerPoint. Did everyone receive this PowerPoint? It says Chapter 15, Part A. We talked a little bit about what is mobile and what is trauma. I did also explain to you the difference between trauma imaging, okay? Trauma imaging. So anytime we are able to modify, Son, how did you are showing me your screen. How did that happen? Oh, how did that happen? Let me go back and see what happened. Okay. I don't think I gave anybody else opportunity. Okay, are you guys still seeing my screen? No? Okay. Okay, now? Good? Perfect. All right. So we talked about the differences between mobile and trauma. Trauma imaging is any time you either are having a competency in the shock room and it's annotated and I can see that it was shock room 4 or shock room 1, whatever it is. I can see the annotation by the technologist, time, date, so on and so forth. Or if the equipment was modified, those are the only. Many times I get questions, Ms. Laura, my person was bleeding at the clinic. That's not trauma. Even though identified something traumatic happened to them, but that's not what's considered trauma imaging. Does everyone understand that? So when we're talking about images on your exam on Wednesday, I want you to pay attention to what you see. What kind of x-ray is this? What kind of x-ray?
The shoulder x-ray?
A dislocation?
This is a shoulder, isn't it? This is a
AP
shoulder. Sorry?
Could it be an AP shoulder?
It is an AP shoulder, and as you're starting to get into it, you're going to have internal and external or neutral. However, the objective here is a shoulder, and we can see that. For shoulder dislocation, what encompasses a dislocation of the shoulder is when the humerus is no longer sitting inside of the glenoid fossa. It's when the humeral head is no longer sitting inside of the glenoid fossa. So when we see the word shoulder dislocation, the objective is shoulder. We could have a hip dislocation. We could have a finger dislocation. We're going to see what dislocation means because there's also the word subluxation. Subluxation. Subluxation means what? Where do you find these definitions? Huh?
A partial dislocation.
It is a partial dislocation, meaning we are not fully dislocated. Subluxation means a partial dislocation. Where did you get that definition from? It's not on this PowerPoint. So where are you looking for these definitions?
So for Bontrager's?
In the Bontrager book. So everyone should be reading. Please do not depend on my PowerPoints. My PowerPoints are only half of what you need. Please go in and thoroughly evaluate the information. Understand? So when we look at a subluxation, it's a partial dislocation. In this particular example, it's talking about the vertebrae is posterior displaced. Can we have a subluxation of any part of the appendicular skeleton? Yes. The answer is yes. Okay? So don't just assume that you're seeing this as a diagram that we'll only see it in the vertebrae. We won't. Okay? Any questions there? So we know the difference between a dislocation and a subluxation. Now let's take a look at this image. Does it look completely dislocated or does it look like a subluxation?
It looks completely dislocated.
It is. And if we outline right here, this is going to be the glenoid fossa. This is your new unit. You are in this unit now. So here you have the glenoid cavity or the glenoid fossa. The fossa is right here, glenoid cavity. This is part of the scapula. Here we have the humerus. This is the humeral bone, the right one. The head is supposed to be articulating with the glenoid cavity. You can go into your Bontrager book and look at a normally or non-dislocated shoulder to compare and contrast. Make sense? Yes? Perfect. All right. So we understand the two differences between dislocation and subluxation. Subluxation and dislocation. One is partial dislocation. The other one is a full dislocation. Right? Here's more terminology. We have the sprain, fracture, and contusion. Sprain. Read it for me, Sharon.
Force wrenching or twisting of a joint resulting in partial rupture or tearing of supporting ligaments.
Good. So here we have a sprain. A sprain of what anatomy specifically? This is where you need to start looking at your words. Words to tell you, to help you identify what it is. It could be. It'll narrow it down. What did it say? It is a joint. It is a joint. So you are spraining a joint. How? By forced twisting causes a partial rupture or tearing, if you're not sure what rupture is, tearing of the supporting, not tendons, but ligaments. What's the difference between a tendon and a ligament?
Tendons hold muscles to the bones, and ligaments hold bones together.
Yes, absolutely. And the reason and the way that I remember the two from each other, do you know what your Achilles tendon is? The Achilles tendon is the actual muscle group that allows you to walk, and it is attached to the bone by a tendon. So for me to always keep it straight in my head, Achilles tendon. So I know it's muscle to bone. A ligament is bone to bone. Got it? Ligaments keep our bones tied together. Tendons keep our muscles tied to bones. Right? Perfect. A fracture is a break in the bone, not a break in the joint. It is a break in the bone. You have to read these words. The words offer you clues. You are investigators. When you are approaching a test, if the PRE taught you anything, this last PRE test taught you anything, you need to pay attention to each and every word. Okay? So a fracture is a break in the bone. Now we have contusion. We've heard of that word, contusion. We hear about NFL, we hear about athletes, whether it's trauma, car wreck, so on and so forth. What is a contusion? We all get them, but we really don't know that they're called contusions. They're bruises. This is where we have a bruise injury without a fracture or break in the skin. You get punched, if you get poked, that's a contusion. It's the bruising. Can we see how all three of these are different? Can we see how all three of these are different? So each one will explain what it is you're looking at. Make sense? These two are very difficult to see in radiographs. Contusion and sprain are difficult to see in radiographs. Fractures, however, are not. Fractures can be, depending on what type of fracture, can be visible on a radiograph. Any questions? Now, when we start talking about fracture, we start talking about alignment. Alignment means how much are they in the same plane? Is the two pieces that are fractured of the bone in the same plane as they originally were before the fracture happened? So fracture alignment is going to talk about apposition. Apposition is a word specifically to describe fracture alignment. Okay? So there are different types of appositions. There are different types of apposition. Apposition is going to talk about fracture alignment. So how many are there? And what does it say in your book about apposition?
There's 3 types, and apposition means how the fragment ends of the bone make contact with each other.
Good. So what is anatomic? Anatomic alignment of ends of fractured bones, meaning that they're not displaced from each other. They are making contact. The bone fragments have stayed in the same plane as they originally were before the break. Here we have the lack of apposition, meaning bone alignment. The ends of the fragment are aligned, but are pulled apart and are not making contact with each other. So they lack connection. And now we have the bayonet. The bayonet, the fracture fragments overlap. They overlap. And the shafts make contact, but not at the fractured ends. Meaning, this is the shaft of the proximal end of the femur. This is the shaft of the distal end of the femur. They are making contact, but they are no longer aligned. Okay? So when we're looking at types of fractures, we will start to discuss them in form of alignment. And some of them are so specific to certain regions of the body that they take on names. They'll have names. The fractures will either start to be called either by a person's name or the way that they appear on a radiograph. However, when we start to look at fracture alignment, they are described in 3 formats. Anatomic, meaning that they are aligned, the fragments are together, they're in the same original plane as they were. The lack of apposition means that they're no longer aligned in the same, but by a little bit. Bayonet means that they are completely not aligned, but they are the fragments are in contact with each other. Got it? Questions? We've seen these 2 words before, Varus and Valgus. Where have we seen these words before?
When learning about, things in relation to the anatomic position.
Good. So when we did, that was in chapter 1 of Bontrager. So we said Varus Angulation. So we're still talking about fracture alignment. Although we're not necessarily talking about the fractured ends, we're talking about the bone ends. We're talking about from the proximal end of the femur, or whatever bone it is, long bone it is, and the distal ends. So here we have the body, their midline, which is the MSP. When we have a varus angulation, it is going towards the break, or the distal end is going towards the midline. Valgus means to turn away. So if we're looking at this femur, the knee is now going to be internally aligned. The knee on the valgus is externally aligned. We start to have some lack of opposition. Does that make sense? Lack of opposition because our fractured ends are no longer in the same plane. Okay? These are describing, Varus and Valgus are describing the orientation of the fractured end. So, what does this mean? Now remember, there is no fracture at the femur. There's no fracture at the femur. At the hip, if we take this all the way to the proximal end, there's no fracture up there. The fracture is here. So the structural stability has been lost. The structural stability of this bone is lost. We have a complete fracture, and now we're looking at the orientation of the opposition. I'm going to stop here before I get into types of fractures so that you can ask your questions.
Can you please explain again the Varus Angulation? I'm a little confused.
Varus and Valgus?
Yes.
Okay. So if you're standing erect, this patient is standing erect. This is a femur, Aurora. This is a femur. This is the knee. This is going to make the knee joint, the distal part of the femur. Okay? I want you to look down at your legs and say, okay, if if my fracture was right above my knee, okay, and it's a complete fracture, if the knee is turning towards your MSP, it is called a varus angulation. If you look down at your knee and it's completely broken and the knee is going away from your midline, then it's called a valgus angulation.
Okay, can you tell me thinking about this the right way? So the fracture is kind of going the opposite direction of where the joint would go.
Correct.
But our focus is where the joint ends up going.
Well, actually, okay, so let's take this picture. Let's take this picture because the one that we just saw is here, right? Where is the MSP of this femur? Right here, right? This is our MSP of the body, is it not? Yes? Good. If this leg or this distal end of the fracture was to go away from this direction, what kind of angulation is that called?
Valgus.
The valgus.
Very good. If it were to go towards the mid-sagittal plane or the median plane, it would be called
Varus angulation.
That's the difference. We're talking about we have a complete fracture. This is one end of the fracture site, and this is another end of the fracture site. We already know we have lack of apposition. But now we're talking about the fractured extremity of this long bone. Which direction is it going? And this is what this is explaining. So that if you were able to see it go this way, you can say, oh, it has a what type of angulation versus, oh, it went this way. What type of angulation? Make sense? It's descriptive in nature. It's explaining what you see. Not that you have to go back and tell the doctor, hey, but that you recognize when you see, oh, there is a valgus displacement or angulation. That tells you, okay, wow. So what do we originally have to do? We have to go back and stabilize this anyways, because when they go back, whether it's casting, which is not likely, I guess depending on the person, or it's surgical, they're going to have to go back and realign the angulations as well. Now, let's just say that they didn't angle correctly. Let's just say the physician didn't place the parts together. Why would knowing the angulation of the midline to the midline is important? Why do you think that would be important? When you get into the lower extremities, you're going to discover that everyone is going to have a different angulation of the femur in reference to the angulation of the head. Okay? So the head of the femur is placed inside of the pelvis, right? It allows us to move our legs. If this angulation is not correct, meaning the placement of the bones were not aligned correctly, a person will have future issues because this joint will not be in sync or aligned like the other side. Your right will not be in the same alignment as your left. Okay? Do you know what I'm talking about? No? Let's see if I have another picture for it. No, these are different types of fractures. So, but do you see what kind of angulation is this? This is the right leg.
That's the valgus angulation.
Very good. Very good. Is it going towards the midline? Or is it going towards away from the midline? It's going away. Well, actually, no. This is going towards the midline. So going towards the midline is the varus. See the knee? See the joint? The joint, this distal is facing towards the midline. Does everyone see that? Yeah? Making more sense? Even though this is considered a compound fracture, we have lack of apposition, right? We have lack of apposition, and now we have what kind of alignment? Towards the midline, we have a Varus Angulation. So this is basically describing this entire trauma. Does that make sense? Jonathan?
So are we looking at the joint, not at the actual fracture?
You're looking at the distal extremity.
Oh, okay. Okay, that makes sense.
Makes sense?
Yes.
And this is the midline. Look at your examples. This is going where? Towards the midline. This is the distal extremity of this long bone. Anyone still kind of confused on what we're talking about? So there's lack of apposition, right? Yes? We're going to learn that this is a compound fracture with lack of apposition and with a, what type of angulation again? Varus.
Is that the right leg?
Had the leg, now if this distal extremity shifted this way, then the distal end would be going away from the midline, and then that would be valgus. Question?
I thought it's going to lateral side. Is that the right leg?
It's going to the lateral side.
So out of the middle line?
Uh-huh. But what specifically, Asias?
Is that
going to the lateral side? The fractured end is going to the lateral side, but not the, look at the direction of the distal end of the bone. Where is it going? Which way is it angled?
I guess that's the lateral side. If it is the right leg.
This is the right leg. This is the lateral surface of the leg.
Yes.
This is the medial surface of the leg. Which direction is this angled towards?
Lateral side?
No. Here it has, this is coming out of the lateral side, but here at the joint, or the distal end, is aiming towards the middle side. I mean, the median side. Do you see it? See the direction?
Okay.
It's going to go towards the midline, and the midline is right here.
Okay.
Make sense? Yes, it's protruding. Yeah. The broken end is protruding out of the lateral side, but it talks about the angulation. So if you have this break and the distal end is going towards the body or the midline or the mid-sagittal plane, it is varus. If its body is going away from the midline towards the lateral side, meaning the break, Asias, would be puncturing the medial aspect of the leg, then it would be considered valgus. Okay?
Ms. Lara, there's a question. Does this also go for upper extremities?
Yeah, it's just talking about the alignments. So if you have a fracture, and it lacks apposition, which means what again? What does lacking apposition mean?
That it's not aligned anymore.
What is not aligned anymore? The fragments, right? The fractured ends are no longer aligned. So if there is a lack of apposition, is there any valgus or varus angulation? That's what we are assessing here. Varus meaning towards the midline, valgus meaning away from the midline. We're talking about the fractured end of the distal end of the bone. Okay? Because look, we have lost structural stability, not down here. It has nothing to do with the foot, has nothing to do with the ankle, has nothing to do with the tib fib. Where did we lose structural stability? In what specific bone?
The femur?
The femur. Any questions? Recapping. We talked about opposition. If we have a fractured ends, we have a fracture. We have two ends, but they have stayed in alignment. That is called an anatomic position, meaning that they did not get out of what was anatomically there before. If we have the lack of apposition, the fractured ends are not making contact with each other, right? However, they can either be displaced or not displaced in an angulation. And then the bayonet opposition means that two fractured ends are not in alignment with each other. They are parallel and touching. Now, I can tell you this. If this person were not to go back and get, it's called a retraction, if they were not able to get these two ends pulled apart and reset, the bone will start to repair itself. The bone will start to repair itself. There will be a lot of osteoblasts forming to repair these ends. So what do you think the outcome would be of this person?
If they don't get it done?
Go ahead, Jalisha.
Are you asking if they don't get the retraction done?
Yes.
If the bone regrows, wouldn't they be walking with a limp?
They would be walking with a limp, but one limb would be shorter than the other. One limb would be shorter than the other. And not only would one limb be shorter than the other, they would have a bulge right here as the bone tries to repair itself just for stability again. Any questions?
Ms. Laura, would that affect their hips?
Yes, it'll affect a lot of their body because their body will compensate for it. Yeah, it definitely will affect. And so that's why when someone gets a break, they always should go back to the doctor, especially when it can impede function later or and if it involves a joint. Because once you have like a break around a joint, it's never, you lack range of motion. Good. So I'm glad y'all are finding this interesting. So we have different types of fractures. We have a simple fracture. The bone does not break through the skin. This is also known as a closed fracture. Does anybody have a simple fracture? Right? Some of us don't even know we have a fracture. We just stumped our toe and didn't realize, right? So compound fracture is where the bone protrudes through the skin. Simple fracture is closed. Compound fracture is open. The bone fragment has protrude through the skin. Let's talk about an incomplete. So a simple fracture means that the bone is broken. The bone is broken, and let's take a look at this one. The bone is broken right here. The bone is broken, the ends are meeting, and nothing is protruding through the skin. Nothing. It looks pretty simple. Okay? Good? I'm just kind of switching in between. But when we look at a complete or compound fracture, we see this fragment going through the skin line, protruding through. So this is an open fracture. An open fracture of the tibia. Not the fibula, but of the tibia. Because it is now protruded through the skin. Right? What is the danger, Juan? What is the danger behind an open fracture? What do you think it is?
Infection.
Could it be infection?
Infection. It is now open. It is open. It is now on the market for all pathology, right? It is now open on the market for all pathology. Okay? Do you want to say hi? Mr. Fung has just walked in. You can see yourself. So they're all here. Hold on, let me see. Let me get your big screen so you can see. There you go.
I'm glad to see everyone's all
they can't
away.
They can't see you. Oh, no, you're right.
Hello, everyone.
Okay. All right. So there's a difference. So when you have a compound fracture, you have the susceptibility of introducing microorganisms, pathogen into the system, right? So not only are you worried about alignment and repair, you are now open to pathogens. Okay? So there are different types of treatment. Before, for this one, you're looking at swelling, you're looking at bone repair. For this one, you now have to incorporate alignment, swelling, and infection control, whether it's bacterial treatment, whether it's whatever it is that's introduced. Okay? Good. So it becomes a higher risk here, because then it can involve systemic, having a fever, some type of reaction, the body's response to this. Okay? Any questions? An incomplete fracture. The difference between an incomplete fracture, it does not go through the entire bone. It's just a portion of the bone that is fractured, meaning it didn't complete the complete break. Make sense? So an incomplete fracture is not a simple fracture because it did not completely go through the entire bone. These types of fractures are described into categories. You have the torus fracture, you have the green stick fracture, and then we have what's called a plastic fracture. In your book, it talks about the different types of definitions for those fractures, right? No? Yes? Right here. So please read. We're almost out of time, so I need you to yes.
I couldn't find plastic fracture in the book.
You couldn't find plastic fracture in the book? Oh, you're right. Okay. That's fine. Well, just make sure that you know the alternative names, hickory or willow stick for the green stick fracture. And I will send you the definition for the plastic. Okay? I think I have it on the nope. I think I only found a picture of what is a torus fracture. That's fine. I'll send you the definition for the plastic. Okay. Now, we talked about dislocation, we talked about subluxation. Now we talked about sprain, contusion, and fractures. Now we've taken fracture and we have now gone into depth about different types of fracture. We talk about ends and alignment. If they are aligned and touching each other, you have anatomic. If there's lack apposition or separation, right, and they have some type of angulation, we're going to talk about the angulation loss, right? And then the bayonet. We have two extremity ends touching, but they are no longer connected, right? They are sitting parallel. These two fragments are now parallel to each other, correct? Yes? Perfect. We also talked about the ends of the breaks when you have a complete fracture. We talked about the ends, whether it's going towards the midline or away from the midline. We have a simple fracture, meaning closed. It did not break through the skin. Talked about a compound fracture. And so in these types, we're incorporating a new word, skin, right? So when you look at a fracture, it's either simple or it's going to be compound. Is the skin intact or is the skin broken, ruptured, torn, whatever? Make sense? Are you understanding how this is descriptive? Don't take these separate. Don't take these separate. It's like saying my junior students are first-year students. So their courses are going to be that. But we're still talking about junior students. So these are describing, when you look at a radiograph, of what you see. So doesn't look like the skin is broken. Doesn't look like this is a complete fracture. So doesn't look like the ends are misaligned. So you're starting to see more because of your intake of knowledge. Does that make sense? We're not doing for interpretive purposes, but you still have to know and have a basic knowledge of what you are identifying. Okay? What type of care would you need for a person that came in like this and a person that came in like this? What would you do different?
Doesn't the one with the break through the skin need a surgery case?
It does, but you have to take an x-ray first. So if you're in the shock room, are you going to be turning this leg?
No.
No, you're not.
Not without a doctor.
You're going to make sure that this is pretty stable. Chances are this person's going to be on a backboard. Chances are they're going to be immobilized so that you don't further cut any arteries. Does that make sense? So I'm passionate about this because I want you to keep in mind what you do and how you do it is important to ensure a safe repair and outcome. Make sense? Yeah? Good. Okay, so we are running out of time. We talked about simple, closed, and incomplete, right? Yes? Other types of, and these words you are very familiar with, aren't you? What does an oblique mean?
The fracture is at an angle.
It's at an angle. So here's transverse, horizontal, right? You've seen this word before, correct? Meaning horizontal break. Here we have an oblique. And what do we have here? What is this kind?
Spiral.
Spiral. Spiral will start off at one end posteriorly and angle down towards the other end. So the break is spiral. Okay? Let me get back to your slides. Okay. Transverse, oblique, spiral. Comminuted. Comminuted is basically fragments. We have fragmented. This type of fracture will usually be seen in like crushing. Something heavy fell on my leg and crushed it. Okay? A barbell fell on my leg, on my tib fib. You can have a comminuted fracture by having fragments. See the word fragments? Good. Complete fractures, which we know are what? Complete, right? They go all the way through and through, can either be described transversely or they look oblique, meaning a line down, or they're spiral. They start off on one end posteriorly or anteriorly high and end up low on the other side. So they have a spiral appearance. If there's splintered or fragments of the bone, it's comminuted. Okay? So these are describing complete fractures. Transverse, oblique, and spiral are describing complete fracture. So how would I outline this? What would be a good idea? How would I outline this, as Betty? Because we saw complete fractures. Fracture alignment. We talked about complete fractures as being a break in the bone through and through there we go. All the way through, right?
Yes.
You have simple, closed, meaning it's just that it did not break through the skin. Compound, it broke through the skin. But we're talking about complete fractures, all the way from the medial side, from the lateral side to the medial side. There is a break all the way through. I would put this under what is a complete fracture versus an incomplete fracture. These are not describing incomplete fractures, are they? An incomplete fracture is going to have a different description. So I would make my category for complete, and I would make my category for incomplete, and then my category for comminuted. Good?
Ms. Laura.
Yes.
So is a simple fracture also considered a complete fracture?
A simple fracture can be considered as a complete fracture, meaning it is a complete fracture, but it did not break through the skin. That's the difference between our fibula here and our tibia here. Okay. Impacted fractures. So this is going to be, so comminuted is usually by way of crushing. Usually something fell and crushed it, something very heavy and crushed your bone. Impacted fractures are going to be, and specifically when you are bracing yourself from a fall. Can you see how this fracture became, and it's called an impacted fracture? Can anybody explain to me why that is? What does it look like? What are we looking at right here, is Betty? What bone is this?
Radius.
That's the oh my god, I can think of the radius.
Good. So the shaft of the radius went into the epiphysis of the radius, right? Or the base. What do you think happened here?
We're falling and they put their hands. They were trying to
brace themselves, right? And this is called an impacted fracture. When one fragment is driven into another. When one fragment is driven into another. Good.
This could be like compacted fracture as well.
What kind of fracture size?
Compacted.
Compacted? No. I think it's going to be specific to impacted. Compacted is not in your definitions that I'm aware of. Anybody help me here? Are you talking about comminuted? Are you talking about comminuted, Isaias? Isaias, are you talking about comminuted?
Okay, yes, I think so.
Yeah, comminuted is going to have different fragments. Even though you're looking at this one and you're saying it's not really fragmented. It just means one section was driven into the other. And how do you achieve those? You use for bracing for impact. Okay?
Okay, thank you.
Breaking the fall. Good. Now, here you have the names, and these are specific. You will never have a Colliers anywhere other than the radius. You will never have a Collier fracture anywhere other than the radius. Just won't. The Collier fracture specifically involves the radius. However, we have a reverse Collier. So if the Collier is described as a posterior displacement of the distal radius, then what is the reverse Collier? It is anterior displacement of the distal radius. So these are specific now. Yes, we have lack of apposition, right? This is showing lack of apposition. We now know what apposition means. Oh, there's lack of apposition, Ms. Laura, in this bone. So let's get to specific, right? It's a transverse fracture, lack of apposition. It's closed, right? It's not compound, considering it didn't move anywhere, but it involves the radius. And so there is posterior displacement. That is the Collier. Had this radial distal end had been over here, then it would have been a reverse Collier. I'm hoping that this is established. How do you study for this exam? Don't just read the words, connect them. Right? Transverse fracture. We see it. It's not comminuted. Right? It's not impacted. Not spiral. It's transverse. Lack of apposition. Make sense? Yes? No? Possibly? Can you hear me? My microphone still on? Mic check. Yes? No?
Sarah, can it be also the bayonet opposition? Since it's not, never mind.
They're not parallel to each other.
No.
Good, but you're putting it together. Thank you. They lack opposition.
So, Ms. Laura, so looking at this the Collier's fracture, the piece of the bone that's posterior, so you're looking at the distal part of the radius from the fracture.
The distal radius is displaced. So the fracture exists. It's a transverse fracture. But what is the displacement? It's not medial, nor it's not Varus or Valgus. It's not. Varus and Valgus is usually descriptive of the lower extremities. So if we're taking the base of the radius, is it posteriorly displaced or is it anteriorly displaced?
Okay, I was just looking at because it looks like if you look at the body of it, body looks like it's anterior displaced. That's what
Not the body. We're talking distal radius. Distal radius displacement, not the shaft.
Okay.
We're talking base. Make sense?
Yeah. Mm-hmm.
Good. Can we have a Collier anywhere else other than the radius? It is in the description. The Collier fracture is only viewing the distal displacement, the distal radius displacement posteriorly. What's the difference between a Collier and a reverse? Is the direction of displacement of what? The distal radius. So if the distal radius is displaced posteriorly, Collier. If the distal radius is displaced anteriorly, reverse Collier. Make sense? So read your words carefully. I cannot stress that enough. Okay? Well, get to the rest of it. Make sure that you align it. Look at it. I've decided I'm only going to try to put no more than 2 radiographs. Okay? Go back and read your words and connect them. These are not 1,000 words that you learn separately. You relate them. Make sense? comminuted, impacted, transverse, spiral, oblique. All of that means something. Open, closed, simple or compound, right? Good. I'm happy. All right. Are you happy? I'll see you guys. Y'all have a good one.
Ms. Laura, can I ask one more?
I'm going to just stop sharing. Go ahead.
I was just going to ask a question about at the very end of the slide, you have like review questions.
Do I have what? I'm sorry?
At the very end of the PowerPoint, you had some review questions.
I did. Did I
like which? No, you did. I just had a question about one of them.
Which one?
So there's one of the questions where it's asking about on the slideshow. There at the very end, you had like a review of fracture types.
Indented fracture, fracture caused by disease process, fracture of the pedicles. Let's not go into those. I really want you to know. I gave you a lot of words in red. For right now, let's stay there because I'm bringing all of this back. You will get an opportunity to incorporate everything on these slides, but we're gonna go ahead and look at the upper and lower extremities and girdles with it. Okay. So we'll get an opportunity to incorporate the hangmans and so on and so forth. Well, the hangmans is going to be more towards the spine.
Yes.
Okay, so stay red. If that helps you any.
So don't worry about the name fractures for the test.
Cahier, reverse Cahier, and I believe we also talked about, let's see. Well, you have to know the ones that are under the red section. So if you're looking at what's a butterfly fracture versus a splinter fracture, yeah, just because I didn't put those into red, they're still highlighted under that section. Yeah, we can wait for the Montegas and Potts fracture. We'll get to those.
Okay. All right. Okay, thanks.
Mm-hmm. Because, like I said, I'm not shortchanging you any information here. We're going to cover, because you're going to see a lot of repeated, especially what is a transverse. Transverse is just a horizontal break. What is an oblique break? What is a spiral break? You know, those are just describing what kind of break there are. Opposition talks about alignment, okay? So you have to start putting and getting an idea there first. And then we're going to start adding more to it. Okay? So this is comprehensive. This is comprehensive learning. Appendicular skeleton. Got it? Good? Dislocation, subluxation. Sprain, contusions. What are those? What's the difference between a sprain and a contusion? Okay, I'm running over time. I'll see you guys later. Bye. Have a great class. Bye. If you have any questions, email me.